Hello, everyone. My name is Alexander Nam, and I'm a law clerk here at Wells Parker. Welcome to today's webinar hosted by the Texas Association for Home Care and Hospice. Today's webinar is entitled Home Health, ADR, TPE, CERT, and UPIC audits, top denial reasons, and the possible impact of these audits on other enforcement activities. Today's presenters are Meaghan DeBenedetto and Christin Thompson. Meaghan is a senior associate at Wells Parker and is a certified professional coder. She has also had experience working for a home health care agency before attending law school. Meaghan has experience with auditing claims, identifying deficiencies, and assisting clients in improving their documentation. Meaghan also has extensive experience working on compliance plans and developing policies and procedures for a variety of different medical providers. Our next presenter, Christin Thompson, is a senior associate at Wells Parker. Before joining Wells Parker, she worked as a professional coder, assigning diagnosis and procedural codes for urgent care, inpatient, and outpatient facilities. She has experience identifying documentation deficiencies and auditing claims for a variety of practice types. Christin assists providers nationwide with developing and implementing policies to improve documentation and coding practices. As a quick reminder, if you have any questions throughout the presentation, please feel free to type them in the chat box, and we will address as many as possible at the end of the presentation. Without further ado, I present your speakers.
Thank you. If you could go to the next slide. Just as is on the slide, this presentation is given for informational purposes only. Your situation can vary based on your individual facts or circumstances, and it's recommended that you reach out to counsel to discuss your particular situation before proceeding. Okay, you can go to the next slide. So first, we're going to talk about TPE audits. TPE is the Targeted Probe and Educate. These audits had been paused for a little bit of time during COVID, but they've been fully resumed for some time now. So some of you may have experienced these or started to get them. On the slide is just some background here on the history of TPE audits. They began in 2014 and have been evolving since that time. TPEs can be either prepayment or postpayment, so either before or after they've actually paid you for the services. And they involve your MAC focusing on specific providers or suppliers that bill a particular item or service. So typically they're looking at one specific issue and then we'll use that to select the claims that they're going to look at. You can go on to the next slide. It's your MAC's job to review treatment documentation and cut down on improper payments. That's what they exist for. The MACs run the TPE program, and they will select providers based on a number of different factors. Some of the reasons that they might select someone is your billing patterns, your improper payment rates, etc. There are many different reasons you could be selected for this process. It doesn't mean that you're doing anything wrong if you are selected. It just means that typically there's something that you are doing different than your peers. There could be very good reasons for that. For instance, you could be a provider who does a ton of wound care, whereas your other, competitors do not. Or you could do more physical therapy than other agencies do. And any of those reasons that make you different, how the data mining works, could get you selected for a review. Getting selected for a review doesn't mean, though, that you're doing anything wrong or that they're going to find anything wrong when they come in there. It just means that there's something that they want to look at to make sure you're doing it correctly. Once you're selected, though, the standard process is that they will select 20 to 40 claims to be reviewed. This could be per provider or per item or service. So, for instance, at a doctor's office where there might be multiple providers, they would select sometimes per doctor within the office. For a home health agency, typically that's not how you bill. So it would usually be per service. It is usually per item or service is what they're going to be looking at. These are then audited, and then you receive a denial or acceptance of those claims, and then you also receive education for any denials that they give. There are some circumstances where more or less claims could be selected in the 20 to 40, but this is the standard process and kind of what you should expect. The TPE process is then further divided into 3 different rounds. So you would get 20 to 40 claims audited in each round if you continued through all 3 rounds. But you can be discontinued from the process when you're deemed compliant. Each MAC sets their own standard for how they determine if a provider is considered to be compliant. Some of these are stated publicly on their website. Some of them will tell you if you ask. Others, it's still just a mystery, and they don't have to tell you. So as you're going through the process, you're trying to get as many approved as possible, obviously. And the lower your denial rate is, the more likely you will be deemed to be compliant and discontinued from the auditing process. If you go through to the 3rd round and you're still not determined to be compliant, then you can be referred to CMS for further action, which obviously everyone would like to avoid. So it's in your best interest to never make it, or especially never fail the 3rd round. Okay, you can go to the next slide. When MACs are selecting who to audit, they typically are looking for outliers, like I said before. They use data mining in order to determine what is an outlier. They look at things such as a high volume of services, a high cost, a dramatic change in frequency of use, a big change in your year over year. This could be going up or down. So if you suddenly start drastically increasing your census or drastically cut your census, it would make your numbers look different from one year to the next, and they might have a question about why or what's going on. Really, any change or statistic that makes you different from other providers in your area can all affect whether you're selected for the TPE process. And oftentimes when I say this, then people are like, well, I want to do exactly what my peers are doing. And unfortunately, there's no way to know what your peers are doing. You can't get those exact numbers and try to make yourself fit. So realistically, that's just, it's great to know that it's data mining, but there's nothing you can really do to make yourself compliant with everyone else. And your best bet is just to make sure that your documentation is compliant. So that way, if you are selected while rendering, medically necessary services, that you would pass. So, it's great to know about the data mining, but it's not really a reason to change what you're doing unless you're questioning if what you're doing is compliant in general. If you are over utilizing different services or underutilizing services that your patients really should qualify for or need, that's when you might want to make a change, but not just because you're wondering what your peers are doing. Providers can also be referred to MACs, though, to go through the TPE process. And these referrals could come from a RAC, a UPIC, or OIG, for example. Sometimes OIG will initiate an investigation, determine that there's nothing further for them to do as far as fraud, but then still refer you to either a UPIC audit or a TPE audit in order just to make sure your services are actually compliant. Oftentimes, this is like if OIG was checking to see if your referral agreements were compliant or something along those lines, Stark rules, things like that. And if they clear you of what they're really looking at, but they still want to check off to make sure your services are okay, that's when you get referred out for a separate audit. MACs tend to target providers with historically high claim denial rates. So if you've been audited before and you did poorly, you're more likely to be audited again. Or if they have billing practices that vary from your peers, or when there's evidence that there's a potential risk to the Medicare trust fund. Evidence could be from data mining, it can be from reports, including reports from competitors or former employees or patients or former patients. Anything that makes them suggest that you could be a risk or that you have some sort of reason to commit fraud. Those could all be reasons you could be referred over to get audited, and then they will look at your claims. And, of course, once they get there, it's hard for anyone to be fully compliant or get every service approved, but you know, that's obviously always the goal. You can go to the next slide. If you're selected for the TPE process, you'll receive a letter stating that you have been selected for review. The letter explains what the TPE process is, what you can expect, and also discusses the one-on-one education you're entitled to as part of this process. Now, that education comes after you receive denials. The letter also discusses how the MAC has the option to refer providers to the RAC or the UPIC if the provider fails to respond to the ADRs. They can also refer you out at any time, depending on if they find something troubling, though, as well. You'll receive the ADRs, which are additions are discussed further later, but they're also utilized as part of the TPE process for each claim and selected as part of the TPE for each claim that's selected. So you get an ADR for each of the 20 to 40 claims that are going to be reviewed. These are often separate letters that will be received until the identified number of claims have been sampled, so the 20 to 40. So there's a lot of paper usually that's being received, which is very difficult to keep track of, and they typically have different deadlines and things like that, so it's something you want to keep an eye on. For the first round of TPE, the claims are selected based on your claim submission date. After that, claims in subsequent rounds are selected based on the date of service. So this is because they want to ensure that you have time to implement the education they provide in your documentation. So they're not going to just base it on claim submission date, because if you submit a claim, you know, after you've received your education, but was rendered before the education, you wouldn't have necessarily had the correct education reflected. And they're really looking to make sure that you are being educated and modifying your practices as a result of that education, which is why they change. And for the second and third round, it's based on your date of service to ensure that you've had time to implement the changes. There's a specific notification language that's up here on the screen that has to be included. The second bullet point is critical, though, because it discusses that CMS has the authority to revoke a provider's Medicare billing privilege if CMS determines that the provider has a pattern or practice of submitting claims that fail to meet Medicare requirements. So if you have a high error rate found, they can revoke you. We're not going to go into detail about the revocation process today because it would require its whole own presentation. But suspension and revocation are risks that you should be aware of if you fail these audits. Things that may result in revocation are repetitive errors, which is another reason why it's so important to keep up with your compliance practices and have a robust compliance plan being enforced to ensure that all denials are addressed. Because if you're revoked, you will not be able to bill or render any services to Medicare beneficiaries, which oftentimes has a waterfall effect over into other services as well, Medicare Advantage plans, for instance, and Medicaid plans as well, or if even sometimes private pay plans have as part of your contractual agreement that you cannot render care to their patients if you are not a Medicare provider. And they often do that in order to make sure that you're meeting Medicare standards. So revocation could be the complete destruction and shutdown of any agency. You can go to the next slide. When you receive the records request, you should gather the requested records just like you would do for any other audit. It's very important that you go through and check your documentation for completeness and accuracy, though, before submission. You should ensure that all required documents are included based on the types of claims requested. The types of documents to be submitted will vary, but some MACs have helpful guides on their websites. So you're going to want to go look and see if there's any guidance before you submit your claims. You should also carefully review the letter you receive because they usually have a quite extensive list of what they're looking for. And sometimes that includes additional information being requested that you might not be expecting, such as earlier dates of service or earlier records to support the current episode of care. Typically that would be like the first episode. They usually want admission documents and things like that. So it's important that you make sure it's there, because you don't want to have a denial from something as simple as forgetting or missing to include some information that could have gotten the claim approved during the first round of review. It's also very important that you comply with the stated deadlines in each letter. Each claim, as I said before, will have likely a different date that it's due. We recommend that you create a spreadsheet to track each request as it's received. That way you can also make sure that you get the 20 to 40 requests, that you're tracking when it was received, when it's due, when it's sent out. And you're going to want to keep a copy of anything that you submit in response to the TPE, in case in the future you get a denial saying you didn't submit something or you didn't respond. You want to have some documentation of what you did. That's why we personally submit everything certified, unless there is a upload portal or something like that, in which case then you can take a screenshot, something along the lines to demonstrate that you timely submitted. If you send it certified, of course, then actually collecting the signature or the certification, showing that it was delivered, and keeping that information for the future, because frequently claims are denied saying that nothing was received, even when they are submitted. So it's something that you want to make sure that doesn't happen, or that you have proof of if it does. Failure to submit records is one of the most common denials, and it can result in a referral to a UPIC audit, and that can happen at any time. So if you fail to respond to the first round of the TPE, they might just not continue you through the TPE process and refer you out to a UPIC audit. And those can be extrapolated, which can result in massive overpayments, hundreds to millions of dollars, usually are associated with it, because how an extrapolated overpayment works is it applies to a percentage of what they paid you over a multi-year period, usually 3 to 5 years. So if you received, $3 million from Medicare, and you didn't submit anything, and they do an extrapolated overpayment, or if they do an audit and they find a large overpayment, they're a denial rate of 100%, they could request everything they paid you back. And then when you're paying that back, they also, of course, charge interest. So it can really snowball into quite a large issue. You can go to the next slide. When you submit your documentation, the MAC does a medical review to identify any concerns. When the MAC identifies an easily curable error, the MAC is supposed to contact you to address the error and allow you to submit the missing documentation. However, I will say that I have frequently found that they don't do this. They frequently don't reach out and tell you that you can submit additional records or things like that, and instead just deny the claims. So you don't want to rely on, they'll reach out, because that doesn't normally happen. But for some instances, like if you had an unsigned note, that can be cured with a signature attestation. For home health and hospice agencies, though, it's more important to understand that signature attestations can be not as effective for you. Not all missing signatures can be cured. For example, a 485, if it's not signed, it can't be cured by an attestation after the fact. That's because it has to be signed prior to billing as a condition of payment. So if you determine that your 485 wasn't signed, it's not like you can go get the physician to sign it now and then submit it. You will still be denied because it was not timely signed. But if, for instance, a physical therapist didn't sign off on their visit note, that can be cured. So it's just good to know what can be fixed and what can't. And for what can't be fixed, especially, you're going to want to make sure that someone is checking those off before billing to make sure that those are done. Obviously, it's best practice for someone to check every note as well, but especially things that cannot be fixed. If a provider failed to submit some notes, those issues can easily be cured, at least in a supplement or addressed in an appeal. But you should keep in mind that the appeals do not necessarily help you in the TPE process. as the appeals do not have to be considered as reducing your overall error rate, even if you win those appeals. This is because the appeal process can take months, and you often will have already moved on to the next round before you get a chance to resolve those. So if you were not deemed compliant in round one and you appealed those claims and you win them, you already are likely partway through round two before the round one results are back, and they don't just stop round two, they continue on through the process. So you have to really get them approved immediately and upfront in order to ensure that you don't move through the process. If the appeals are processed quickly enough or the rounds are delayed, it's possible that the appeals can reduce your denial rate, but that is up to your MAC, and it's not a guarantee. We do know of at least one MAC who put the second round on hold and would not proceed with the auditing process until the results of their appeals are received to avoid this. However, this is highly unusual and is definitely to the provider's benefit if or when this does occur, but you shouldn't count on it. TPEs are typically returned in 30 days for prepayment claims and 60 days for post-payment reviews. These are just averages, though, and can vary widely. The actual timelines, TPE reviews are supposed to be conducted by, the actual timelines can vary widely. TPE reviews are supposed to be conducted by qualified individuals, for instance, registered nurses, or certified coders. This means that they should have some qualifications before reviewing your records, so they should be familiar with these types of services, but that does not mean that your results will always make sense. I have had nurses reviewing dental claims, for instance, and they've never worked in dental or understood. And for instance, just because someone is a nurse doesn't mean that they necessarily understand home health, because that can be very different from other types of medicine that they're used to practicing in. So just because someone is a nurse does not mean that they're going to understand your business or that their decisions will make logical sense. However, they are supposed to be qualified. Typically, the audit process is very much a bean counting experience. They have a checklist that they're moving through and are just checking for each item to see if it's there or not. These are not based on common sense or arguments about, the fact that the care was necessary or good or benefited the patient. It's about whether or not you meet each box. They really are not looking overall for patient outcomes at this point. This is purely, do you have what is required for payment? So oftentimes, I hear this isn't fair, or that, we rendered this service, the patient needed it, the patient benefited, the patient improved, or things like that, which of course I can understand and how frustrating this is, but that doesn't really make a difference in this audit process. It's just about whether or not you have the documentation they require. Right, you can go on to the next slide. We've kind of already gone over some of this, but it's how the TPE process works. It's the flow chart of it. You first get a letter saying you're selected. Then you get told the 20 to 40 claims to be reviewed. You go through that review process. If the claims are denied, you get invited to a one-on-one education session. For this education session, it's very important that you attend. Some providers decline, thinking that they know the rules or that they won't benefit from the education, but it's very important that you attend and take advantage of the education and really understand why your claims are denied. You're allowed and you should ask questions while there. You're meeting directly with the people who will be reviewing and overseeing you through this process. So it's your best chance to really see how your MAC interprets their rules. There can be disagreement about what a rule means or what a requirement is, but hearing what your MAC thinks the rule is the best way to get your claims approved. It doesn't matter if they're right or wrong, or if they're misapplying the rule. You're going to want to abide by their interpretation, especially during the TPE process, because that's telling you how to get your claims approved. So after your education, you're given at least 45 days to make changes and improvements to your documentation. Sometimes this is extended. For instance, we've had clients who had up to a year between rounds, and they kind of thought that they'd been forgotten or that, you know, the TPE process had stopped, and it had not. They came back. So, but you can't count on extra time. So you should assume that you're going to have the 45 days. After you get your education session, that means you have a pretty short period of time to understand and implement these changes to make sure you're going to pass the next round. After the waiting period, 20 to 40 new claims will be selected, and you'll go through the whole process again. And if you are not compliant, then you'll get education again, and at least 45 days to implement those changes before moving into round 3. At any time, you could be determined to be compliant, though, of course, and removed from the process. But if after 3 rounds you're found to not be compliant, you'd be referred out for other CMS action. If found to be compliant, you will not be reviewed again for at least 1 year on the selected topic. You can have multiple TPEs, though, covering different types of claims at the same time or back to back, or after, you know, one after another. You can still also be audited by a UPIC or a RAC or other contractors. So don't think that once you go through a TPE, it means you're free to go for a year. It just means that the specific narrow issue that the TPE was looking at wouldn't be looked at again for 1 year in the TPE process, with a small caveat that if your billing practices significantly change during that year, they could audit you again, even during that 1 year time frame. So they're still watching you, and if they see you make a massive change, they're likely to come back. So there is no real protection there, and you shouldn't count on any. You can go to the next slide. This flow chart also depicts some of the information I was just going over. It shows how if you make it through the rounds, when you get out of the TPE process, or when you might be sent on for further action, you really do not want to get to round 3. If you fail round 1, you know, it happens. You get the education, you implement it, you modify your practices, and you really buckle down for round 2. Everything needs to be put into making sure, though, you're passing round 2 and that you truly understood why you didn't pass round 1. But you really don't want to get to round 3 because the risks associated with failing this round are so potentially devastating, being sent out to any number of further actions, such as a UPIC audit, a suspension, or revocation, which, as I'd already said, you know, can shut your agency down and are some of the highest risk areas a provider can face. Therefore, you really want to engage with this process and the education to avoid going on to round 3, but especially failing round 3 and any further action. If you do move into round 3, though, I would say don't freak out, stay calm. You've gotten 2 sets of education at this point. You should have a good idea why you're failing and what needs to be done. And it's just very, very important at that point that you fully take advantage of that education and make sure you're making the changes. That way you will pass that final round. All right, go on. On the slide are some of the most common denials throughout the TPE process, especially for home health and hospice agencies. The number 1 denial reason we see is for missing or inadequate face-to-face documentation. The face-to-face requirements have changed over the years, but they've been a requirement now for a very long time at this point, yet they still are a major issue for agencies. The compliance percentages for face-to-face documentation is incredibly low. It is required that actual notes of the encounter be collected from the physician, that the primary reason for the services be documented at that encounter. Another common issue is if the face-to-face is not being performed by the certifying physician. There are some exceptions, whereas if the patient's being referred from acute care or a mid-level working under the supervision of the certifying physician, But these arrangements need to be documented, and the certifying physician still must have reviewed the face-to-face, especially if it's coming from an acute care facility and it needs to be part of their record. So there's a number of rules there for the face-to-face that people tend to mix up on, especially though the primary reason. If the reason that the patient is receiving home health is not mentioned in the encounter note, you will typically always fail that in an audit. And it needs to be mentioned in more than just a passing away. There needs to be like something actually written there, not just that the patient has diabetes, something beyond that. If you really want to ensure that you're going to pass. I know this is difficult because you're not the certifying physician, and you're trying to run a business and speak to these certifying physicians, and they don't want to be told how to do their job. But it's incredibly important that you only accept referrals if they're going to meet these guidelines, because at the end of the day, the certifying physician does not get in trouble if their documentation fails to meet the requirements. You're the one who has to pay it back. And I've been on the side of calling these physicians and asking them for more records or more information or more documentation. And I do know how difficult it is and how impossible of a standard it is. But if at the end of the day, you are responsible. Other issues that come up are records not submitted, which we've kind of already discussed. So you need to make sure that you're actually submitting the records. Another issue is failing to document the date of the face-to-face occurred in the physician certification. We recommend that the date of the face-to-face be just incorporated into the 485 to ensure this requirement is met. However, oftentimes once agencies have included that into their 485, they still leave the box blank. So it's important that you're going through and checking to make sure that the date is actually filled in, and that date incorporate or reflects back to the date of an actual face-to-face encounter. You should be conducting regular internal audits and reviews of your face-to-face certification documents. This should be done before any claim is billed out, but you should also just be having someone else check off in general to ensure that all requirements are being met due to the high risk associated with these documents and the fact that these issues cannot be rectified after the services are billed. All right, you can go on to the next slide. After you complete each round, you get offered one-on-one education with the auditor. This can be completed via a phone call. It's sometimes over a webinar platform. Very, very rarely they have done it in person, but a number of providers request this and it's almost always denied, so I would not expect that. It should be noted that if you call the MAC after you receive your results, sometimes they'll do something that's like an informal discussion with you right when you called in. And then they write off this informal discussion as your education. So you need to make clear if you do call in that the discussion you're having is not supposed to be considered your education. Because typically if you just call in after you receive your results, you aren't prepared for this. You haven't fully reviewed all the results. You might not have everyone with you that you want to participate. You just don't want some sort of 5-minute discussion to be them considering you to have been educated. You need to prepare by reviewing every single part of the decision. So every single claim line, every single denial. Make sure you have questions about every denial if you don't know why it happened. Have everyone on the phone that you would like to be present to engage in the education. And make sure that you are getting the most out of this as this process is supposed to be your chance to understand denials. If you're going through the education and you don't understand the reviewer, if they're going too quickly, if they use words or cite to statutes you don't understand, this is your education. It's your chance to ask them to repeat themselves, explain more, slow down, send you copies of the statutes they're citing to. Any of that, just to make sure you truly understand why these are being denied. You can go on to the next slide. Education should be individualized. It should be claim specific and conducted in a format that is interactive. So the provider should be able to engage and ask questions of the reviewer. Anyone can be on the call with you, so you'll want to have critical members of your organization who will participate. This can include your biller or your legal representative. If you're told something is denied for a reason and you're not familiar with that reason, you should ask for the regulation or rule so you can review it. You can ask questions about the actual claims that were reviewed in the audit. So you can use actual details to understand the denials to ensure you understand, what they're saying and why the claim was denied for the next round. Go on to the next slide. You then receive an audit results letter. This will say why your claims are denied. You can then be given or calculate your error rate at that time. Sometimes they tell you what it is. You can include, or it'll include details of any appeal. These again have strict deadlines, so you want to make sure that you're complying with the appeal deadlines, and deadlines for recoupment will be earlier. So just make sure you're paying attention. There'll be demand letters, things like that. And so you want to make sure that you're appealing timely and that you don't have any surprises with money being taken back. You can go on to the next slide. You can be referred to CMS at the MAC's discretion after the 3 rounds. However, you can also be referred at any time. They don't have to wait for you to complete the 3 rounds. So if something is very concerning to the MAC, for instance, if they find fraud, modified records, things like that, they might send you on at any point. That could then result, as I've said before, in an extrapolated audit. These risks are why we recommend hiring external assistance through this process. It's in the interest of everyone to have assistance from the beginning and not wait until you failed multiple rounds to reach out, to make sure you're giving this the best chance of passing. Also note that if you refuse the education at any point during this process of any of the rounds, that's noted when you're referred out. So that refusal for education could result in negative inferences about your agency, saying that you weren't trying to improve or something along those lines. So you definitely want to make sure that even if you don't have questions, come up with questions and don't refuse the education. Go on to the next slide. If you have sufficiently low error rate, you're removed from the TPE process after any of the rounds. After the TPE process, MACs continue to use data analysis to monitor your billing practices. And if your billing practices change or revert back to what they were before the audit, then that'll be noted and you can result in a resumption of the TPEs or further action. There's a few different ways they can result or calculate your error rate. It can be based on the dollars denied versus dollars that would have been reimbursed if a claim was paid. It can be based on the specific number of claims denied or some mix of these processes, and each MAC will choose their own method. And then each MAC will also choose what is an acceptable denial rate. So keep in mind that what the denial rate is that is acceptable could vary based on jurisdiction. You can go on to the next slide. Here are some examples of what they've said in the past of what their error rate thresholds are. These could have changed, but they were collected during previous cases we've worked on, but should not be taken as guidance for what the current rules are, because as I said, they can change, and the MAC can change their rules pretty much at any time. You can go on to the next slide. These are compliance tips for the TPE process. For instance, go to your MAC's TPE webpage. You can review the documentation checklist and education info. Make sure your point of contact is correct and up to date in PICOs. They use this to contact you, and you can miss vital communications if not done correctly. Make sure it's not a former employee, for instance. Conduct internal review of records before submitting them and check for additional documentation. Make sure you're replying timely. Track your ADRs to make sure no deadlines are missed. Do not refuse the education. Identify what changes to your policies and procedures or documentation are needed, and then make those quickly in order to be compliant. You can go on to the next slide. And this is about ADRs and comparing ADRs and TPE audits. ADRs are part of the TPE process because you receive an additional document request. Sorry, what? Oh. For the 20 to 40 records, however, they're also a separate audit process that can occur at the same time or completely separately from TPEs. Plain ADR is less risk because it's just one claim and not part of an audit system. However, ADRs can result in a referral for further auditing, so they should still be taken seriously. TPEs review more claims and therefore are higher risk. As a reminder, you can be involved in multiple TPE processes at the same time. You can receive multiple ADRs at the same time and can receive both at any time. So multiple audits or types of audits can occur all at the same time. Christin now is going to take over to further discuss ADRs and some other auditing processes.
Thanks, Meaghan. So next slide. ADRs, additional document requests, are part of Medicare's overall medical review program. The authority to request an ADR is found in various sections of the Social Security Act. The most important thing to understand is that a MAC has the authority to review any claims at any time. As a Medicare participating provider or agency, the cost of doing business is that you're going to get audited. It's not a question of if, it's a question of when, and whether you're ready when the time comes. Next slide. ADRs are done prior to payment of a claim and are usually handled by the MAC, although some can come from other contractors. There are various reasons that providers receive ADRs. It could be an element of a claim might need a prepayment edit. It could be a national edit. There could be a specific national review program focusing on specific ICD-10 or CPT codes. We're seeing a lot of these program-focused ADRs right now. Could also be a provider-specific edit based on reasons or edits developed by the MAC's internal medical review or program integrity unit, and those could be based on prior audit findings. All prepayment edits can key in on a beneficiary's ID, the provider's NPI, the service date, particular codes, or other data points. Next slide. So MACs must be able to review a claim in an apples to apples fashion. For example, the standards of one procedure, diagnosis, place of service type cannot be used to determine the appropriateness of another. This is particularly tricky when the reviewers are assessing a family of codes, and special attention should be paid to the similarities and differences for distinguishing codes within a family. We see this a lot more frequently on our Part B providers who may be seeing a lot of evaluation and management services. Codes that have different levels within the family. Next slide. For ADRs, you're going to receive a letter sent to the address that's on file. You need to make sure that address is current. We have a lot of providers who find out that they were sent an ADR, but their address isn't current, so it was sent off into the abyss, and they never receive it, and then they become untimely. An ADR has a 30-day response deadline. So again, if your address isn't current, you run into issues when you're not able to file things in a timely manner. One MAC states documentation received after the 30-day deadline may not be completed within the 45-day review window. And if a provider fails to respond by day 40, the claim can be automatically denied. The timeline is critical. One of the major denial reasons related to ADRs is that documentation isn't received. It's hard to believe that a provider wouldn't respond to an ADR that they have received. It could be the quick timelines or the problem, along with gathering the requested records and submitting them. As Meaghan mentioned, you may receive a single ADR, you might receive a whole batch of them. Regardless, that small window applies to each one individually. It's really important to be aware of those deadlines and to make sure you're getting the documents submitted in time. You can always supplement, which is important as long as you make sure that you put your ADR cover letter on those supplements and make sure it's fairly clear to the contractor that you're submitting these as a supplement to the original submission. Next slide. So this is a really quick visual of submitting the ADR. You're going to send each ADR packet separately. The ADR cover letter should always be included and put on the top of your record. It can be helpful to submit the documentation through the electronic portal. It will get there instantly. The processing times are faster, you get the results faster, and then you get paid faster to the extent your claims are payable. I'm old-fashioned though. I send everything by mail that I can. It's your preference on whether you use the electronic portal or mail in your response. In either case, always keep a copy of your record and the tracking information. Many providers don't do that, and when a claim gets denied, they bring us on board and are unable to provide an exact copy of the files were submitted to the MAC. A lot of times they'll offer to re-pull it from the EMR, but we can't be sure that's exactly what was sent previously. As a result, we don't know with certainty what the reviewers, the MAC, are looking at. So it's really, really important to keep a copy of those records on file that you've submitted in response to the ADR. If the MAC overlooks something, we can say we have a copy of the record, we have the page numbers, and we can point them to the specific spot in the specific file. The reviewer could say a record is unsigned, but we can point to the physician's signature on a specific page, for example. And that's a quick way to correct wrong assessment on the part of the reviewer and get an easy win. Be sure to pick up the phone and call the MAC with any questions. They do have a provider education department and provider resource line, so it's always worth asking, particularly if you've identified a mistake and it's something that is easily correctable. Next slide. What's the difference between an ADR and being placed on prepayment review? ADRs are typically initiated by a provider's MAC, and they typically relate to a particular probe or edit conducted by that MAC. They can focus on specific services, lengths of stay, provider-specific diagnosis, or other reasons. In contrast to an ADR, being placed on prepayment review is usually going to affect 100% of your claims, and it can last a year or more. It's an intensive process, and rarely less than 100% of your claims are going to go through the review. That affects the revenue stream for your agency. Next slide. For prepayment reviews, UPICs will typically send notice to the provider if they're selected for review. However, we've seen quite a number of providers and agencies who've never gotten a notice before, who just suddenly started receiving requests for documentation, which can be alarming. There is a provision in the Medicare program integrity manual that says they should provide notice, and you should push back and make sure you get that documentation if you have not received it before you start receiving requests for documentation. Private payers are increasingly placing providers on prepayment review, and unlike Medicare and other government payers, very few private payers contracts go into very much detail on their processes. When it comes to how the provider may be placed on prepayment review, they also typically don't address the scope of a prepayment review. So it can be very uncharted territory to get into a prepayment review on the private side. From a practical standpoint, the payments can be delayed for to 6 months or longer. So we want to make sure that whenever possible, we don't jeopardize that revenue stream, and we try to get the prepayment review request satisfied and you lifted from that status as quickly as possible. Next slide. With any audit, our advice is always the same. Never ignore the problem and review the claims and associated documentation before you send them in. There are many of the things that we pointed out before. Make sure medical necessity is substantiated, make sure the services billed are documented, make sure the documentation complies with local coverage determinations or national coverage determinations. If they don't, if there are missing elements, go to the provider to prepare an addendum in line with Medicare record keeping principles. We want to make sure that we fill in those gaps whenever possible. You may find you're missing a face-to-face note. You go ahead and request a copy of that before you're sending in documentation. Clearly marking any addendums that are made to the chart, not altering the original documentation is critical. We want to make sure that they're signed off with the date that the addendum or correction is made to make sure that these things are accepted. If your providers are doing all of that, they are able to make an addendum to the documentation to clarify, to correct, or to elaborate. It's important to take advantage of the initial review of documentation that you're doing before you submit this to the MAC and it becomes a part of the administrative record. You also want to check whether the claims are coded, billed, and paid correctly. We think so much about documentation being the patient's narrative, but we also want to make sure that the back end affecting payment is also reviewed. Next slide. So what is a post-payment review? Post-payment audit occurs after a provider has submitted a claim to receive payment. Basically, they're looking at claims that have already been paid. To the extent there are any issues determined, for example, eligibility requirements weren't met or the claim isn't supported, they would then ask them for that money back through a demand letter. There are a lot of different sources for post-payment review. We're seeing data mining like Meaghan mentioned, and of course, contractors can basically look at the data however they want, which makes it easier for providers to get selected for that post-payment review. Some of the things they might see when they're looking at that information: are you billing more than your peers? Did you have a change in your reimbursement last year to this year? There are so many different ways they can look at it, and it's really one of the big reasons that providers get targeted for post-payment review. You can be placed in post-payment review because of complaints or referrals from other contractors. When you get a post-pay review notice, one of the first things we do in our firm is that we file a Freedom of Information Act request in most situations. We want to know what's going on. Where did the source come from? Was it a referral? Was it a complaint? Or was it the more common reason? Is it data mining? It takes a long time to get that information back, but eventually we do get it, and it can be very, very helpful in narrowing or identifying what the scope of the review is. Sometimes we can get some very specific details from the contractor's investigative file. Next slide. There are several big concerns with post-pay reviews. The money has already been paid and used for overhead and salaries, and now the payer is asking to get that money back. Getting the money together when it's demanded from the provider can be very difficult. Post-pay audits are sometimes extrapolated. When overpayments are extrapolated, you may be talking about a lot more than just the sample of claims that's been submitted, depending on the error rate and universe of claims. We see too often several thousands of dollars quickly turn into hundreds of thousands of dollars. There are also oftentimes lots of errors identified for each claim. Each of those must be reversed for the claim to be payable. So when you go through the appeals process, you might be able to win the face-to-face issue, but then you still have to prove the medical necessity denial. The more denials you have, the harder it is to win them because you're trying to defend multiple aspects of the claim. Medicare can deny your claim for any number of reasons. In order for you to get paid, you have to win on every single denial that they bring to the table. Next slide. Here are quick CMS appeal statistics. These haven't really been updated since 2020, so we're a bit outside of this, but The main point is it's better to get this all sorted out in the medical review process, respond with solid documentation, and get your claim paid, because going through the appeals process is long and time consuming, and also you might not win. If you look at 2012 and then at 2020, those numbers have dropped dramatically for fully favorable and partially favorable. You don't want to get into the appeals process. It is very resource intensive. You have multiple levels of review, and each of those takes months to complete. Next slide. Real quick before we jump into suspensions, I do want to mention, and this is affecting Arizona, California, Nevada, and Texas, the period of enhanced oversight for new hospices. This is a program that rolled out in July of 2023, and it is triggered for new hospices, which may be those newly enrolling, those who have undergone a business structure change, like a change in partnership, those with 100% ownership change or reactivation if the agency was previously deactivated. It can last for 30 days to a year. And the reason that I bring this up here is because we're seeing very few claims reviewed under this period of enhanced oversight, but very aggressive actions like revocations and suspensions occurring as the result of these reviews. So if you receive a notice for this particular program, be on top of your game, make sure you're really reviewing those claims before you submit them as thoroughly as possible. One of the things that can happen is a suspension. What is a suspension? They're terrible. Your revenue stops, and it's going to stop very likely for a minimum of 6 months. Sometimes suspensions are extended when the contractor hasn't completed their investigation, and that can double the length of the suspension to a whole year. You might be getting paid for claims, but that money is being held in escrow until the investigation is complete. So even though claims are going through, you're not getting any of the funds. When your payer mix is heavily Medicare, this is a huge amount of your reimbursement and can be debilitating if you're not getting paid. There are several different reasons that a provider can be placed on suspension. One of the most common that we are seeing are credible allegations of fraud, and the other would be the abusive billing that Meaghan mentioned earlier, which we're seeing most frequently, or I'm seeing most frequently with the period of enhanced oversight reviews that are being conducted. Next slide. So what is a credible allegation of fraud? Unfortunately for providers, the barrier to establish this for CMS is extremely low. It could be based on a probe audit. They'll tell you that the medical review results for the probe audit weren't satisfactory. It could be a hotline complaint, more of the data mining. It could be from a law enforcement investigation. When you receive your suspension notice, the letter generally references 5 claims and will note the documentation didn't support the services were medically necessary. This can be their credible allegation of fraud, and you are suspended for 180 days. They don't have to tell you anything about their actual analysis or how they applied the Medicare coverage criteria in your rebuttal. You could take the opportunity to respond to those 5 claims that they did identify, but again, we often see that the investigation that's occurring during suspension is going to take the full 180 days. In terms of knowing whether you're suspended, you're going to get a notice letter, but they usually send it on the day of or the day before suspension actually occurs, so you don't really have notice. Basically, on March 4th, they issued the letter, and today you receive the letter and find out that you were suspended yesterday. Next slide. As I mentioned, after receiving notice of expense, after receiving notice of a suspension, you do have the opportunity to submit a rebuttal. We always recommend submitting one, even though it doesn't often result in the reversal of the suspension, because it's part of your defense. They're giving you some of the allegations, even though those are usually generic and they only relate to 5 claims. It's your opportunity to respond to them, to to respond to them to collect and submit additional documentation. Sometimes they say we interviewed beneficiaries who tell them they didn't receive the services. You could potentially go back and ask those beneficiaries to sign affidavits. If they agree that they receive the services, you can do things to begin to develop your defense. When they finally release you from suspension and you go through the appeals process, you have the best documentation you can, and you're ready to support those services. Next slide. Some conclusions here. The potential results of a bad audit can be increased. Likelihood of post-payment review, overpayments, repayments, cash flow shortages. It would lead to suspension of your Medicare payments. We know how difficult that can be, and then it could also lead to revocation, which is an entirely different administrative process. The things you can do to minimize impact of these types of audit and suspension mechanisms is to start compliance now. If your practice receives any kind of notice of prepayment, post-payment review, or suspension, get counsel involved immediately. The sooner you do, the sooner that provider or agency can get back to business as normal. You really need someone who knows these processes and knows what it takes to go through the audits or the suspension as fast as possible. More than anything else, never ignore a notice from Medicare. It won't go away. And it is a basis for them to escalate to more severe administrative actions. Next slide. Thanks everybody for attending. I know we're a little bit over time. If you have any questions, my email address and Meaghan's are available here. Feel free to send your questions to us directly or shoot them. You're always welcome to give us a call. We're happy to help. And again, I appreciate you guys hanging in there and attending today.
Well, thank you so much to our presenters. We don't have any questions in the chat. And thank you to all of our attendees for joining us today. I will be sending a copy of the PowerPoint slides tomorrow. And if you have any further questions, definitely feel free to reach out to them. I hope you all have a great Wednesday.